Good afternoon, everyone, and welcome to the National Council's live webinar. This webinar will be a demonstration of the two different types of naloxone, nasal spray and auto-injector, that Adapt Pharma and Kaleo generously donated to the National Council and have been received by your organization. Before we get started, I'd like to bring to your attention that this webinar is recorded and will be available within 48 hours on the National Council website. Additionally, if you experience any technical difficulties during the webinar, please call Citrix Tech Support at 888-259-8414. My name is Lillian Wolfenson, and I will be your moderator today. I am a project assistant here at the National Council. The demonstrations will be given by Dr. Joe Parks, who serves as the medical director at the National Council. We will be accepting any questions via the chat box throughout the webinar, which will be answered at the end. And now I would like to turn this webinar over to Joe.
Thank you, Lillian. Appreciate it. And I want to thank everybody for attending who's on the phone and on their computer with us. Next slide, please. And you already heard who I am, so let's go over the learning objectives. So we're going to talk about a little history of the opioid epidemic. We're going to talk about some clinical facts about naltrexone and overdosing and withdrawal states. We're going to go over how to recognize the signs and symptoms of an overdose and describe how you can respond using both naltrexone in either of the dose forms that have been donated and then calling 911. And then we'll talk about getting people linked to appropriate services. Go ahead, Lillian. So opiates are one of the most significant substance use disorder concerns in the U.S. today. It is rapidly growing. It's still much smaller than alcohol in terms of damage and death, but it certainly is increasing much faster and much more in the public eye. In the 1990s, there was a major focus in this country on treating pain. Pain was undertreated, and opiates were used to treat non-cancer pain, and there was a rapid expansion into things like low back pain, neck pain, other types of chronic pain, and this was based on subjective reporting, and there wasn't really enough focus on the danger of addiction, the danger of misuse, and the downside of these medications that often only have limited utility. Go ahead. So here we are in 2018, and every day, on average, 172 Americans die from a drug overdose. That's about 7 people an hour. And the vast majority, 116 of those, about 2/3, are due to opiates. So opiates are responsible for 2/3 of the opiate deaths, and there'll be 116 people on average that die today. If it keeps increasing at current trend lines, it'll have the potential to be at 1 million deaths by 2020. Next slide, Lillian. So what are the risk factors for overdose? Well, you're at more risk if you're using multiple things, if you have multiple drugs of abuse, if you're using it with alcohol, if you're using opiates with benzodiazepines in particular, both will cause more suppression of your blood pressure and your respiration. There's more risk when there's a variation, an inconsistency in the strength and the purity and potency of the product you're getting. This is particularly problematic with heroin, which of course is not a standardized product, and you get on a different batch or get it from a different dealer, and you don't really know how strong it is until you've used it. If your tolerance level has changed, if you've voluntarily detoxed yourself, gone cold turkey, if you've been in the hospital, if you've been in jail, if you've been in a treatment program, your tolerance is now much lower, and a dose that used to not get you in medical trouble can kill you. If you switch the method of taking the drug from sniffing or eating to injection, that way there's none of it destroyed by your digestive tract before it gets to your cell receptors, so it's much more potent by injection than by sniffing or eating. People that are physically fragile, that already have other medical illness, respiratory problems, heart disease, and of course people that are very low weight, taking the same dose as somebody at a higher weight will get a larger effect. Psychological health, it's often difficult to tell if some of these overdoses were intentional or accidental or maybe a little of both. People intentionally kill themselves with opiates and people accidentally kill themselves. And when you're struggling with depression, when you're struggling with psychosis, you don't think clearly and you don't make your best judgments. Using alone, there's no one there to assist you when you get in trouble. And transient living, of course, exposes you to living alone, to changes in the drugs you're getting because you're living in different regions, often getting drugs from different dealers. And then that overconfidence. I really know how to handle heroin. I know how to handle OxyContin. I've done this a lot. I know what I'm doing. I'm an expert. And frankly, people aren't. They make mistakes. Next slide. So what are the signs? How do you identify somebody in an overdose situation? Well, they may start to look blue from not getting enough blood out to their skin, their hands. That'll often be the lips and fingertips will show it first. Especially African American people, it's best to look at the nail beds. They'll show it more easily than other parts. They will become more limp. They will start moving more slowly. Their face will become pale. The heartbeat will slow, then become erratic, and then you may have trouble finding a pulse. It'll become so weak. People throw up. They pass out. And what starts out as kind of rough, juicy breathing progresses to gurgling, then snoring, then choking noises, and then it becomes irregular and stops. Also, people may be just sitting there with their eyes open awake and you shake them and they don't respond. You rub on their chest with your knuckles up and down, which is a standard way emergency medical technicians try to arouse someone, and you get no response. Those are all signs of overdose. Next slide. Let's contrast that a little with earlier in the process. What's the difference between what it looks like when somebody is just really high as opposed when they're actually in an overdose? Well, it starts with the muscles being relaxed and being slowed down, and then progresses into the slow heartbeat, the pale, clammy skin, the nail beds, or the lips turning blue. It starts out with slow, slurred speech, and then progresses into deep snoring, gurgling, and then the breath becomes infrequent. They start out by looking sleepy, but are still responsive. You can shake somebody, you can rub them on the chest, you can shake them some, and they respond. And then they become more somnolent, harder to respond, and finally unresponsive. And just whatever you do, you don't get a response back. Now, at any point you suspect an overdose is underway, you want to err on the side of giving the medication sooner, not later. So when in doubt, administer naloxone. If you're asking yourself, are we getting in a dangerous situation? If you're asking the question, you probably should be administering the drug. Go ahead. Naloxone is very short acting. It's an emergency medication. It has no psychoactive effects. People don't get euphoric, they don't get a buzz, they don't get high. And it lasts in its protective effect of blocking the opiate response only for about 30 to 90 minutes. So it is a temporary relief, which is why as soon as you administer naloxone, you need to call 911 because somebody needs to get there to continue treatment. After 90 minutes, they may start nodding off again. They may become more slurred speech. They may start making that gurgling noise again. This is particularly true if they've taken a very potent opiate like fentanyl that is 100 to 1,000 times more potent than things like OxyContin, or if they've taken very long-acting opiates. Methadone and OxyContin are longer-acting opiates. Sometimes when people wake up, they'll want to start using again immediately. And of course, you want to dissuade or prevent that. If you've administered naloxone to somebody and you're waiting for the ambulance, this is no time for them to be taking more OxyContin, more methadone, more heroin, whatever it is. And you can at times see mild withdrawal symptoms after administering naloxone, and I'll go over those in a minute. But that doesn't eliminate the risk for the overdose reemerging. So at times, someone will be in an overdose situation, turning blue, breathing irregularly, non-responsive. You'll administer naloxone and you'll get some mild withdrawal effects. They'll want to use more. And even if they don't use more, you can see a reemergence of the overdose 60, 90, 120 minutes later. So this is a rapid evolving situation. Naloxone buys you time. It doesn't solve it for good. Go ahead. Well, here's some pictures of the different dose forms. There is a multi-piece cartridge nasal inhaler, where you drop the little tube in the plastic cartridge with the white cone on the top, and then you push on the bottom and it creates a spray coming out the white cone, which you've pressed in the person's nose. We've been donated some of the Narcan nasal sprays, which is just put it in the nostril, hold the other nostril shut, and pump the plunger. 2 pumps is the usual application. Then there's injection techniques. We've received the NZO Auto-injector, very easy to use. Just press it against the leg, push the button, and it'll automatically send an injection needle. You can do it on trousers, you can do it through pants. Very easy to use. And then there's traditional intramuscular injection, where you have to draw the medication up out of a vial. You take the plastic top off, you draw it up in the syringe, and you use the syringe to inject the person. This is actually the type that's most commonly used in programs where they're distributing it to people that have a long history of injection use, because these are people that are very comfortable using injections. Next slide. So how do people respond and awaken? There we go. How do people respond? Most will awaken slowly. The usual dosage is 1 injection with the NZO or 2 pumps with the nasal spray. In 3 to 5 minutes, you should see a person become more arousable, more alert, more responsive. Their breathing should become normal. Their skin color should return. It may require an additional dose, especially if they've been taking fentanyl, which is extremely potent. Many people will feel confused and embarrassed. Some will feel irritated. You need to tell them that they were having an overdose, you couldn't arouse them, they weren't breathing, and you've given them Naloxone and the ambulance is coming. I'll go over the withdrawal effects in a minute. It's very rare for people to have severe withdrawal. These are usually, they are discomfortable, they can be discomforting, but they are not medically dangerous effects. And they will wear off as soon as the Naloxone wears off. Next slide. So withdrawal effects you can get in a mild form temporarily in someone dependent on opiates when given Naloxone include muscle and joint pain, getting a runny nose or tearing in the eyes, becoming nauseous, having abdominal cramps, maybe vomiting or diarrhea, getting goosebumps, chills, sweating, feeling anxious, being depressed, having intense craving for more opiates. Of course, if your stomach's upset and you're feeling nauseous, there's no appetite, and people can be irritable and confused. This is really the classic withdrawal symptoms people get when they are dependent on an opiate. They've been taking OxyContin, heroin, whatever for quite a long time, and they stop taking it. They don't have access. They decide to stop taking it. People will get sick and have these kind of withdrawal symptoms for 3 to 5 days, and then come through it. Next slide. These are treatable. In the case of Naloxone, they're temporary. So now we're going to watch a video, brief little video showing us how to use the auto-injector. Go ahead, let's begin.
Hi, I'm Allison, a pharmacist. Today I'd like to go over how to use your Naloxone product. It can be really difficult in an emergency situation to remember everything that you may have learned about Naloxone. So feel free to come back to this video from time to time to review the information here so that you can always be prepared in the event that you witness an opioid overdose. So you call 911 and grab your Naloxone. Now what? Is injectable Naloxone that comes in a box similar to this, and each box contains 2 doses of active drug and 1 training device. Today I'll be using the training device to show you how it works, and I highly recommend when you get your box of NCO to open it up, take out that trainer, and give it a try. That way you can see what it sounds like, see what it feels like, and you can always be prepared in an opioid overdose situation. So the trainer, the white cartridge, you remove it from the case, and it starts speaking to you. This trainer contains no needle or drug. If you are ready to use, pull on red safety guard. To inject, please blast it against outer thigh. Inject fully and open place for 5 seconds. 5, 4, 3, 2, 1. Injection complete. And as you can see, it does a great job walking you through how to give a dose of naloxone, so all the work is done for you. And that is SEO.
Okay, so the sound quality will be better in the YouTube address clip we will send to you separately. Anyone on this phone call will get an email where you can directly access the YouTube video. It will have better sound quality, but we wanted you to see what the device looked like in action. Next slide. Now we're going to go through the same with the nasal spray naloxone. I'm afraid the sound quality over the webinar platform will be difficult on this one also. So we will be sending you that email that has the YouTube address you can click on to see it direct on your computer or laptop, and you'll get decent sound quality. But let's go ahead and run it, see what it looks like. Okay, so what I like about this second video is I think it's more realistic. You're not going to find somebody in an overdose situation sitting up on their own in a chair smiling at you. They're going to be sitting down in a slump or laying on the ground in a slump. And the second video included the process of checking their breathing, positioning them and tilting their head, and then rolling them over into the recovery safety position on their side after the Narcan was administered. You should do the same when using the Enzio auto-injector. You should check for breathing. You should try to arouse them. And after you administer it, you should roll them over on their side. So if they do vomit, they don't inhale it and suffocate from having their airway blocked. Let's go on to the next slide. So putting it all together, naloxone temporarily reverses opioid effects. You do need medical attention, so as soon as you administer the naloxone, you want to be calling 911. You do want to give the naloxone first, then call 911. It is safe to administer. All states at this point have Good Samaritan laws. They've been updated rapidly, and they're continuing to be updating, and the protections are being made broader. We would have given you materials on it, but they would have been out of date within 30 or 60 days because of the rapidly improving safeguards that are offered to people that take Good Samaritan actions. Can be used by with anyone who may be at risk, prescribed opiates, or has a substance use disorder. And most common question I get is, well, what happens if I give this to somebody and they're not having an opiate overdose? And the answer is, if they're not dependent on opiates, absolutely nothing. All you've done is either gotten their nostril wet or given them a pin, an injection prick with an injection needle. But do call 911 when they wake up. If they're irritated or confused, try and keep them there till the ambulance arrives and dissuade them from taking any more opiates until the ambulance arrives. Next slide. So how you help? You check for signs of an overdose, you administer naloxone, you call 911 after putting the person in the recovery position. And then you stay with them and try and comfort and reassure them. Next slide. Now, of course, after that, if you have access to the person still, you want to follow up and check and ask them, was this a suicide attempt? Were they trying to kill themselves? Do they need mental health services in addition to substance use disorder services? But be aware of your surroundings. This can happen in the street. It can happen in dicey places. Don't touch any drugs or needles laying around. And be aware, some people may want to get away. They may not want to be there for the ambulance or for the police to arrive. Do your best to encourage them to stay and get help. Next slide. I want to remind you all of how to listen some listening non-judgmentally script lines that are very helpful. This is good for family, friends, if you have associates that you're worried about. Telling them I'm concerned about you. When your tolerance is low, you can be at high risk for an overdose. Or asking someone that you know has a dependence problem, do you have an overdose plan? Do you know about Narcan? Do you know about Naloxone? Are you carrying something with you? Your safety is an important thing. How can I help? If you feel the need to use the substance again, please don't do it alone. Don't be, protect yourself. And I'm not an expert on this, but I can connect you with someone I trust who is, and maybe they can help you. Offering help never hurts, and offering reassurance almost always helps. Next slide. So those are the prepared comments. It's really amazingly simple to use. It's hard to make a mistake. And if you do make a mistake, there's no downside or harm from the mistake, unless the mistake is not administering it when somebody was having an overdose. That's about the only dangerous mistake you can make. I'm ready for questions.
Hi, great. Thank you, Joe, for the presentation. We do have a couple questions coming in, and a reminder to all the attendees that you can just type your questions right into the chat box, and we'll get to as many as we can. The first question that came in was, I was trained to do rescue breathing after calling 911 until the ambulance arrived. Is that appropriate?
If the person is not breathing, you should do rescue breathing. For most people, they will begin to breathe on their own if it is an opiate overdose and you've administered naloxone in one form or another. So certainly assess. If they're not breathing, then proceed with rescue breathing if you've had the training to do that.
Great. The next question is, what is the safest way to dispose of expired Narcan?
Safest way to Narcan. It can really be thrown out in the garbage. It does not need special disposal. And by the way, on expired, be aware, if you ever find yourself in a situation with someone in overdose and you look at your Narcan that you've been carrying in your purse and you find it expired 2 months ago, go ahead and give it anyway. Expiration dates are very conservative. And usually most drugs are good for at least 6 months beyond their expiration date. The danger you'll have is giving an inactive drug. If you give it, the danger you'll have of not giving an expired drug is maybe you could have saved someone and you didn't. So don't get entirely stuck on the expiration date.
Okay, great. The next question is, how should the event be charted in their record?
It should be charted as a regular progress note, and you should change their plan that they need further assessments and supports. It's certainly merits a team meeting, a reassessment of the level of service they're getting. There needs to be reach out to them immediately after they're done with the hospital or even while they're in the hospital, but it definitely should be recorded in a treatment record if you're a treatment professional administering the naloxone. If you are not a treatment professional and you know this person is getting health care from someone, whether that's primary care or a substance use disorder treatment or treatment for mental illness, let their treaters know. Remember that obligation of HIPAA applies to healthcare providers. If you're not in a provider relationship and you're speaking about a friend, you have no legal obligation, and even if it makes them pissed, you'll be helping them and maybe saving their life.
Great. The next question is, if you need more than one dose, do you administer in the same nostril?
You could use either nostril. I would usually use the other nostril, thinking maybe I'd get better absorption than reusing the same, but it's not terribly important.
Great. The next question is, can you give some clarity on temperature exposure? Many attendees are concerned about leaving naloxone in their cars during extremely hot or cold days. Is that something that they should be concerned about?
I think there'll be more problems from hot days than from cold days. These are solutions that do not freeze very easily at all, but it would be best not to leave it in a car in the summer when it can get above 100 degrees in the car. All drugs stay more stable longer at moderate temperatures or cool temperatures.
Okay. And then this next one is
a little easier for you ladies. You have purses. Men, you'll have to figure out a way to carry it.
Great. This person says that I have attended several trainings around naloxone. One trainer stated that one should administer naloxone and then wait 3 to 5 minutes before administering another dose. Another says that if the initial naloxone is not effective immediately, then administer the dose. And they want to know your thoughts on that, which is correct, which is not.
Yeah. Immediately, I think you have to give it at least 60 seconds. For an injection or a nasal application, you should notice some difference in 60 seconds. But I think how urgent it is to do the next dose depends on if they're still breathing or not and how regular and effective their breathing is. If they're turning blue and only taking an occasional breath, I probably would give the second dose after 30 or 60 seconds at most. If they're not breathing, I might give the second dose even quicker than that. If they are breathing okay, but they're still just kind of naughty and heavy, then I'm going to wait the full 3 to 5 minutes before deciding. So look at your trend line. Are things starting to get better? Well, I can afford to wait. Are things starting to get worse or not getting any better? I better act again.
Great.
By the way, there's no danger of taking that extra dose. You cannot overdose on naloxone. There's no such thing as a naloxone overdose.
Great. The next question is, are there any written protocols for the use of this medication on site?
Many organizations have protocols. We'll go back to our team and see if we can put a couple out either on the website or maybe in a follow-up email to those of you on the call. Let's put that on our to-do list, Lillian.
I've got that down. The next question is, are there any naloxone-resistant opioids?
No, not particularly. If you take a very large dose, you'll need more naloxone to reverse it. It's what's called a competitive inhibition. They're competing for the receptor, but the naloxone binds much more tightly than the opiate molecules. But if you're taking a large amount of a more potent opiate, you need a larger amount. But I'm unaware of any reports of an opiate where naloxone is not at all effective.
Great. And then we have time for just one more question. How do you dispose of a used or expired cartridge?
Dispose of it in the trash. There's no specialty disposal for this.
Okay, great. Thank you, Joe, for the presentation.
No, absolutely. It was a pleasure. And I hope everybody listening keeps their naloxone with them and go out there and save a life.
Thank you all for joining today and have a wonderful day.